Hi, everybody. This is the International Academy for Clinical Hematology, broadcasting live from Nashville and Paris. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is a great pleasure and honor to welcome you to this first broadcast of a new series entitled The ICH for Patient. And I think we all believe that having relevant and accurate information available to patients and families has become a crucial component of a state-of-the-art clinical care. Not only does it help the patient and family to better understand the disease, it also helps with decision making and coping with the diagnosis and burden of symptoms. So, as health professionals and under the umbrella and within the spirit of the ICH initiative, we felt within the executive and steering committees that our duty is to elicit the information needed by patient and deliver it in a simple way that is easy to understand. And we're very fortunate tonight, this morning, this afternoon, wherever you are, actually to kick off this series with a very special broadcast dedicated to CAR T cells. And we are extremely privileged and blessed having with us actually one of the first patients who received CARs almost 3 years ago, and he will give you the details. Mr. David Such and his wife, Patti, thank you so much for being with us. And of course, our expert panelist on this topic today is Dr. Dholaria from the Vanderbilt Cancer Center in Nashville in the United States. So without any further ado, I would like to start, and of course, the audience can participate, so please don't hesitate to send your questions using the chat box or whatever tool you have access to. My first question to you, Bhagi, is just to explain in lay words, what does it mean? What does CAR T cell mean? You know, is it a car we should drive? What's the difference with a bus, for instance? Yeah.
Yeah, thank you. First of all, thank you, Professor Moti, for inviting for this wonderful initiative from ICH and David and Patty to be our guide and sharing their story with us. So, CAR T cell therapy is a short form for a new form of cancer immunotherapy called chimeric antigen receptor T cell therapy. In this treatment, we collect patients' own immune cells through a procedure called apheresis, basically separate out parts of the immune cell from patient's blood, and then genetically reprogram this immune cell to insert a new mutant virus to allow this cancer cell to become super powerful cancer-fighting cells. And that's what we call CAR T cell or chimeric antigen receptor. These are artificially enhanced immune cell from the patient's own immune system. And these immune cells are then reinfused intravenously on patients with different type of cancer diagnosis. And they go in the patient's body and they find the cancer. They have specific receptor to target different type of malignancies. And then they grow significantly inside the patient's blood, find the cancer and kill the cancer cell. And this appears to be one of the most effective form of cancer immunotherapy in selected group of patients with different type of blood cancer. And now we have several FDA approved CAR T cell therapy manufactured by different private companies for different types of hematological cancers.
Thank you. So, David and Patty, it looks like we have some brave soldiers. Was it this way it was explained to you? And how did it happen? Can you please share with us your experience? Because I guess it's not obvious when, the doctor come to the patient and say, okay, now next step, we're going to give you some cars. I guess it wasn't an easy thing to understand.
It was not. It was not. So thank you for having us, and we appreciate your time and the ability to share my story. It was interesting. We're in Florida right now, right, enjoying our retirement. We were here in Florida, and all of a sudden I had this huge. It felt like an avocado growth on my neck, and I had to shave around it. And I thought, God, that's strange. I thought maybe it was a infection or something. So I contacted my doctor, and he gave me some antibiotics with the hope that this thing would go away. It did not. And when I got back from Florida to my home state of Kentucky, I decided to go see the doctor, and the doctor didn't like what he saw and asked me if I knew any ENTs, ear, nose, and throat doctors, that I really needed to go see one. So I went to a friend of mine who's an ENT, and he did a biopsy. He did what's called the needle biopsy initially, and then had me come back the following week. But the next day, he asked me to come in, and he said, "Man, I got some terrible news for you, but you've got cancer." I go, "What?" He goes, "Yeah, you have lymphoma." And I was alone. My wife and was visiting some of our grandkids down in Texas. And how do you process that? You have cancer and you're by yourself, and what do you do next? So I started making some phone calls. I got a hold of a friend of ours who was an oncologist, set up an appointment, and I went into the Norton Cancer Institute in Louisville, Kentucky, met with the doctors there. And as a result, the doctor said, we think we can get this with what's called hyper CVAT, which is a very aggressive form of chemo. So we went through 6 months of chemo. The cycles, originally we thought we'd go through 4 cycles, then 6, then 8. And within weeks after, I declared that I was cancer-free, we rang the bell. And unfortunately, 3 weeks later, the cancer came back. That's when I got serious. I said, all right, how do we get this out of me, this mantle cell lymphoma, which is the type of lymphoma that I had? And I decided that I needed to go and get a second opinion. And I talked with some people at the Leukemia Lymphoma Society, and they gave me some contacts at Nashville with both Vanderbilt and with Sarah Cannon. And so I went down and met with both of them, and I said, hey, the first one that picks me wins, right? So I went down there, and the first person I met was Dr. Dholaria. And came in, and he shared the story of how CAR T works. I had a little bit of knowledge from my doctor back in Kentucky, but I got a better knowledge of what it was going to take. Met with both the folks at Vanderbilt, the folks at Sarah Cannon, and I decided, based on the way in which the research hospital took an approach to managing this disease, that's where I wanted to go. And I was selected to be part of that clinical trial, the ZUMA-2. So that's how I found out about it. That took me to that step right there, the start of the process. And thank God that Vanderbilt was doing a clinical trial, and I qualified for it at that time.
So Patti, because obviously you were around and you were hearing all of these bad news, you were looking into these hyper chemo. We do have a few weird words that we use in medicine. Actually, now what you're telling me, hyper CVAT, is definitely maybe not the right thing to say. So how did you feel about it, Patti?
When we went to the oncologist the very first time, the interesting thing was he had this idea, we're going to do the hyper CVAT. He goes, but we also have next steps. We could do a stem cell. We could do this CAR T thing. So we had some information, a brochure about what CAR T was. But of course, at that time, it was not approved for, second, what's the word I'm looking for?
Second level.
Second level. So he had to fail the CAR T first. And then when our insurance wasn't so excited about us doing CAR T, David was able to find the clinical trial. And we got a lot of information. They have a lot of information. And the wonderful thing about going to Vanderbilt and being with Dr. Dholaria is that they know all this stuff, and they could tell you, we're going to do this, we're going to do this, this might happen, we have this idea. And so, yes, it's scary, but at the same time, we just felt like we were with people who could handle what was going to happen. And also a big help, which I know that as physicians, but David's attitude was very positive, and he was going to fight. And so at no time did we sit back. And at no time did the doctors tell me we're worried. They just kept saying, that's okay. This is what we expect. We can take care of that. And I did my best to stay in that lane. Okay. We're going.
Wonderful. So I can see that having a clear plan is very important, and being always optimistic is even more important. So Baggy, apparently they consulted with you. You had this clinical trial, and we know the value of clinical trials and the importance to advance the field and the benefit. So I guess after consenting, David, providing the explanation, we have to go through all of these details. So what are the next steps?
Yeah, Dr. Modi, so we have a very comprehensive evaluation process for any patients who is selected to undergo CAR T-cell therapy at our center, which is very similar to many transplant CAR T centers across the country. But it starts with, of course, as you correctly mentioned, confirmation of the diagnosis and signing the consent for the trial. Once the consent is in place and the patient is approved to move forward, we put patients through different levels of evaluation. Basically, they meet with our CAR T transplant nurse practitioner for evaluation visit, and it's a almost 2-3 hour long education session, basically. And we go through each and every process, minute details about the chemotherapy we use in preparation for CAR T, the expected side effects of CAR T, such as cytokine release syndrome and neurotoxicity. And we educate them about how long they need to stay close to Vanderbilt, which is 30 days required for the protocol, as well as our institutional standards. And we also give them the roadmap of what's going to happen once they leave Nashville and how long they have to come back for the scans and the follow-up. During the evaluation, they also meet with our social worker and our case manager, who kind of walk them through the financial implications of some of this treatment. Of course, if you are on a trial, most of the stuff is paid through the company which is running the trial, but we still have to have insurance authorization in place for other unexpected complications during the CAR T. They also meet with our pharmacist at some point to kind of go through the medications. And if needed, David, I don't think when you were going through CAR T, we had our older adult geriatric transplant clinic, but now, since that time, we have implemented that any patients who is going through CAR T above age 65 or with multiple 3 or more comorbidities has to go through this geriatric older adult evaluation. So basically, it's run through our transplant CAR T physician in collaboration with a physical therapist and a geriatric specialist. And they implement like a bunch of tests, such as your cognitive evaluation, your physical functioning, your nutrition, and your mental health capacity, and all those things, and provide us a guidance of how to optimize patients before they go through the CAR T. So it has become quite robust, and that way we tackle the expected complications before they happen and optimize the patient.
So, David, it looks like that the whole full orchestra was working around you, and each one playing his instrument or her instrument. But then Dr. Dholaria mentioned the explanations about the leukapheresis, the chemotherapy, the toxicity, CRS, neurotoxicity. How did you digest all of this information, and what were the main concerns? Because my best guess is that sometimes we physicians are concerned about things that are of less importance to the patient and vice versa. So how did you react to this flow of information, a huge amount of information just delivered suddenly to you?
I wasn't worried so much about all that because I just finished 6 months of chemo that basically took me to the edge of death, I felt. And when Dr. Dholaria and I sat down, I knew then that that would be my first choice, would be to go with someone that had the research behind not only the medicine but the research behind the work. And when I was explained all the steps, I understood them. There was no surprises. I knew what was going to happen next. I knew what we needed to do in order to what we needed to do in order to get the job done. So I was not concerned about that. Dr. Dholaria and and I met with a ton of people. The social worker was great help to me. Matter of fact, they explained how I could get Social Security disability early, and I did that. And they said that you could end up with Medicare early. I did that. So that all of the pieces that were given to me as part of this clinical trial at Vanderbilt were all very helpful. And as a result of that, I really didn't have any fear. Everything from understanding the leukapheresis and how long that would take. I had to stay a minimum of 30 days, and I beat that record. I got 43 days where I had to stay in Nashville at a furnished apartment. And a lot of, I did have some side effects, but I always learned that there was a plan B, right? You got plan A, here's what we're supposed to do, but there's always a plan B, something else that would, help take care of those things that you didn't expect.
Patti, did you have the same reassurance as David, or you had your own hidden concerns?
I didn't. David wanted a solution. And before we left Kentucky, he asked our doctor there, what if I do nothing? And he said, well, I'll give you 3 to 6. So we were all in. When it came time for CAR T, please do something. David doesn't sit back. He did a lot of research, and we were confident, with that we needed to do something, and this was our something. And so we went all in. And like David said, yes, he had, some of the cytokine release and symptoms and the neurotoxicity, which we have giggles about, and we know some fun things he did during that time. But you just gotta keep going. You gotta be a part of it. If you're making this decision, then you have to go all in. You can't do it halfway. Once you're going, you're going. And I think that's how we approached it.
Fantastic. So, Baggy, now let's talk about the different steps that led to the infusion and then the follow-up. So first of all, we need to get the soldiers. So we call this apheresis. We get to collect the lymphocyte. And how was this experience for you, David? Can you just describe how did it happen?
Well, I told you there always had to be a plan B. And when I came down to do the initial apheresis, there were 3 days worth of testing, of which the first day they tested you for everything, COVID. And guess what? I got a phone call 30 minutes after having that test, and they said, by the way, you have COVID. Oh. So I got thrown a curveball right away, right? And so we had to stop. I couldn't do the apheresis. And so I had to go back, and it took 6 weeks almost to clear 3 tests saying I didn't have COVID. So at the time, it was during a time that a lot of people were getting COVID, and I don't know how, but somehow I came down and I had it. So we had to reset. And after we went and reset and went with plan B, it came back, went through all the tests again. I went through things like brain scans, MRIs. I went through, cardiologist test with them, making sure my heart was strong enough. I mean, they tested me more than I've ever been tested in my life. Right. And I think the only thing they didn't do was a colonoscopy, but I had that already done before I did the chemotherapy. That was a real pain. And well, I'll forget that. But I knew that things were very thorough, and I felt very, very, very comfortable with the people's hands that I was in. I wasn't being treated by one person. I was being treated by a team. And I could really feel that. And I could sense the fact that they weren't all acting on their own independent thoughts. but collectively they were acting together to make sure that I was getting set up for the best possible outcome possible.
And the day of the actual apheresis, it was still COVID, so I had to stay outside the room, but he's in this room for a bit of time. And then someone walked out the door with this little cooler. And I was like, wow, there it goes. It has started and off his cells went. That's a memory for me. Okay, here we go.
So you could see this small yellow bag.
I saw the bag. She saw the cooler, but yeah, I saw the bag after they did the apheresis. It took a while. It took maybe 4 or 5 hours if I remember correctly. It was a process, and they said it would take the time. You just stayed warm, and
they brought us lunch.
Right, brought us lunch. And, yeah, you were sitting there, and you were letting the machine do what it needed to do to pull those T cells out, those white blood cells, and make them available. And it wasn't that much. It was about the size of half of a beer can's worth, It wasn't that much, but man, it was magic, right? When they sent that away, I knew, and then all of a sudden you're wondering, okay, when is it coming back? They said it could be 3-4 weeks or 3 weeks, 2-3 weeks, and that's the big mystery. When is it coming back? So you go home, you're home, and you're waiting for a phone call. Hurry up, where's it at? But the time was all, it was all less than what they originally had told me that it would take in order to get those cells back.
Superb. So the soldiers are ready now, and maybe I think before infusing the CAR T cells, patient needs some chemotherapy. So maybe Baggy, you can explain why do we need this? Because we thought that the soldiers are already fully equipped. They're going to go and fight and track every single cancer cell, but still you need a little bit of salt and pepper of chemo.
Yes, sir. So the whole idea behind the conditioning or lymphodepleting chemotherapy before CAR T is to suppress David's immune system to make space for the CAR Ts to grow. The early version of the CAR T was done without any additional chemotherapy, and those CAR T trials did not work that well because the CAR T failed to grow in the patient's body. Although they were very effective in the lab, in the Petri dish, when these cells were infused in the patient, it really didn't work that well because patient's own immune system was quite immunosuppressive and they didn't allow CAR Ts to grow. So nowadays, almost every patient who go through CAR T cell therapy, whether in a clinical trial or outside the clinical trial, receive several days of chemotherapy. Now, that chemotherapy is relatively gentler, of course, compared to hyper-CVAD. We commonly use 2 drug combination, drug called fludarabine and other is called cyclophosphamide. And these drugs are given typically over the course of 3 days. At Vanderbilt, this is done completely outpatient in the clinic. So patients comes in the morning, do the labs, get a bag of chemotherapy, and then goes back to the local apartment or hotel, wherever the patient is staying. And typically this chemotherapy doesn't last too long in the patient's body, but it does the job of what it's supposed to do, which is suppressing patient's immune system. But we do expect some of the side effects from this chemotherapy. Typically, we don't see as much of hair loss or not so much nausea or diarrhea, but it does cause fatigue. In David's case, I believe you had a fever reaction, which was very unusual.
Yeah.
We thought it was related to fludarabine related, and he had a high fever even before the CAR Ts were actually administered. So that was a little bit odd reaction, but that's not common. But we do see drop in the patient's blood count for the first 10 to 14 days after this chemotherapy. And typically after that, the counts recover pretty quickly. Sometimes patients require some blood transfusions, but that's not that common.
So David, do you confirm that it was relatively mild and well tolerated as a chemo?
Yeah, compared to what I first had, it was nothing. It was like a walk in the park, right? But I do remember the fever, and I do remember them being very concerned, very cautious. They wanted to make sure that it didn't have some kind of infection. So we got tested for, viral and bacterial infections. And I mean, it took an extra couple of days. Plan B, right? Plan B kept coming up, but there was a plan, right? There was also those other additional steps that we knew that were available, and they took them. They gave me some. I don't know if it was antibiotics or something, but they just wanted to make sure that we had no infection going on. And then once we confirmed that, we were ready for the reuniting day.
Excellent. Baggy, so now you did this famous lymphodepletion, the space is empty, you can infuse the cells. What's going to happen next?
Yeah, so we give CAR Ts, and again, the bag we receive from company is very rather small. It's around 150, 200 cc of the volume. So it's a very small volume of product, and we just give it intravenously, and then we wait. These CAR Ts go into patient's body and they expand as soon as they see the lymphoma. And then we wait for some of the possible side effects of this therapy. Because David was on a clinical trial, he was admitted, I believe, for around 7-10 days for the monitoring. So he was actually in the hospital for the close monitoring of the side effects. And nowadays we are doing it is all outpatient. But the typical side effect starts anywhere from 48 to 72 hours after the cell infusion. And the first side effects in the majority of the patient is fever. And that goes with a condition called cytokine release syndrome. Basically, these CAR Ts are supercharged, and when they see the lymphoma, they start expanding and dividing, and they bring their friends through chemicals called cytokines. And these cytokines can raise the patient's body temperature. Sometimes it can lead to low blood pressure problem, or even occasionally, like in David's case, require some oxygen support also. We are getting better at treating this nowadays. We have an antidote for this cytokine release syndrome. There's a drug called tocilizumab, which is given an intravenous injection. And that works majority of the time in taking care of the cytokine release syndrome. And typically, this cytokine release syndrome kind of fades away after 5 to 7 days from the cell infusion. And then you sometimes see neurotoxicity, which is also known as immune effector cell therapy related neuroencephalopathy. And that's seen in a small number of patients compared to the CRS, but it can be really scary, Dr. Mohte, because it's almost feel like patient has lost ability to form words. We sometimes see confusion, disorientation, tremors, and in advanced cases of neurotoxicities, patients sometimes go into this comatose stage where they don't respond when they call by their name. And we have some treatment for that, and it can last actually a little bit longer than sometimes CRS even. But typically by week 2 or 3, most of these CAR T related side effects are subsided, and patients are recovering from sometimes even the side effects of the CRS treatment, sometimes dealing with some infections. But by week 3, end of week 3, week 4, patients should be feeling close to half of their normal self in terms of energy, appetite, kind of moving around independently. We typically discharge patients as soon as the CRS and neurotoxicity are resolved, and then they just come and see us in the clinic.
So it seems like from the doctor perspective, everything is under control. How was it on your side, David and Patti? Were you so comfortable, or were you worried about the CRS, these neurotoxicity? How was your stay? You spent some time inpatient.
I'm going to let Patti explain some of the things that happened, because I don't know if I was there because of, I had every effect possible, right? I'm going to touch everything and do everything that I can, right? It's kind of what that ended up like. But when I first got the cells, it was kind of anticlimactic. Here you're going to get these cells that are magic, right? It's the magic fairy dust. And so I had to play a song, right? So I played the song. You ever heard the song from Peaches and Herb, and it's gone, reunited because it feels so good? I got reunited with myself, right? And so it really was anticlimactic. They thawed the cells out. They ended up putting the putting them, intravenously back into me. And then it was like there were like a dozen people in the room, some of the doctors, some of the nurses, and also we're looking at each other going, oh, that's it? Then the fun began, right?
Yeah.
Like Dr. Dholaria said, several days later, we start having some of those CRS and neurotoxicity effects. I'm going to let Patti explain some of them because some of those I don't even remember.
Yeah. And again, like Dr. Dholaria said, his CRS did not last but a couple of days. It was quickly addressed. And then neurotoxicity, the things that they were testing for all along. Interestingly, I was so surprised because I'm thinking he's doing fine. He's doing fine when he had to draw his clock and tell us what day it was. But the nurses noticed immediately that it was taking him just a little longer. And I was like so proud of him. He knew everything, but they knew it was coming. They knew it was coming and they were ready for us. I don't think it was bad for more than 36 hours. He could not draw that clock. He could not write his name clearly. Somehow or another, he managed to take his phone and change his profile picture to a photo of the balances in our investment accounts. That was the most exciting thing he did, that he doesn't remember how he did it. But other than that, they had a plan. They had a plan. And it goes right back down, and you could immediately see the change back to, I can write my name, I can draw a clock, I know where I am. It was not, we didn't find it scary. It was more amusing, actually. But because they just made us feel so, it's okay. We've seen this before. We're going to do this. I don't know. Yes. That's how we felt. That's how we felt.
I did feel the blood pressure go pretty low. I have low blood pressure to begin with, and it got low, and it got, they had to give me some medicines, and there was a point where they were thinking of, if I didn't rebound by the next day, they were going to put me in the ICU to get another special medication, but they were able to manage it, and we were there for a total of 10 days. We were originally supposed to be there 7, but always looking to the max, right?
He wanted the full experience. He needed to check every box. We told Dr. Dholaria that's just how Dave whirls.
So it looks like you won a 3 days bonus.
Yeah, it's what it felt like, I felt like I was in the resort, right? The Vanderbilt Resort.
No, I think there is really an important message in what you said, Patti, is although it could be scary, but the attitude of the team around you and reassurance and telling you, explaining, we know how to deal with it. It's going to be temporary. I think this is really important. And thank you for sharing this experience. So that was a short-term Bhagi. What about the long-term, the follow-up, the surveillance? Is it just we infuse the cells, they go through these early complications, and then the job is done? Or what to expect?
Yeah, so I would say most of the job is done. By the time patient leaves, they go through the PET-CT scan to assess the response to CAR T-cell therapy. And then we bring them back at 3-month mark after the CAR T infusion for another PET scan. And if a patient is responding well to CAR T-cell therapy, then we assign them to a nurse practitioner in our long-term IEC, or immune effector cell therapy clinic, which is kind of based on our long-term allotransplant clinic, where patients comes every 4 to 6 months, get a regular scan, and we monitor them for some of the late toxicity of CAR T-cell therapy, which is very important for patients and the caregiver to understand, because these are the live drugs. Once the CAR Ts are administered, they can actually stay in the blood for several months and continues to have some of the positive effect, which is curing cancer, but also some of the negative effect of CAR T, such as it doesn't actually discriminate between a healthy part of the immune system, which protects us against some of the infections. We typically have to check the immunoglobulin levels in patients who had received CAR T-cell therapy, because we have learned that patients who had CAR T therapy in the past can have extremely low level of immunoglobulin. These are the proteins in the blood, help us fight different infections, common bacterial infection, viral infection. And if you don't replace this immunoglobulin with a bag of a donor immunoglobulins called IVIG, or immunoglobulins bag of infusions, patients can end up with some serious infection sometimes. We also keep them on some of the prophylactic antibiotics anywhere from 6 months to a year to prevent some viral reactivations such as zosters, also some of the pneumonia prevention medications. So patients do have to take some of these prophylactic antibiotics for several months after the CAR Ts are done. We also monitor them very closely for relapse of the lymphoma. So of course, CAR T works, but sometimes we see relapses after 3 months, 6 months, a year after the cell infusion. And for that, they need to be monitored closely with regular CT scans. And really, we work very closely with the local physician in this situation because many of our patients travel several hours to come to get CAR T. So we actually collaborate with the local oncologist to get some of these labs done, immunoglobulin infused, get the scans done. And we see them either in person or remotely, like on Zooms we are talking today, to review all the information. But we actually keep seeing patients for almost 5, 6 years. Some of our patients really doesn't want to go to the local doctor because they feel so comfortable with our team. So they keep calling us even several, like now we've been doing CAR T for over 8 years now. So I have still those long-term survivors coming once a year to see us.
So David, it looks like that after this shot, they were keeping you on a sort of a tight leash. How did you live with this? Was this something of a great burden on you, or actually things went smoothly and nicely? Can you share your experience with this post-CAR follow-up? And I guess there was a disease evaluation to make sure that these nasty lymph nodes, cancer lymph nodes, just vanished and were killed by the immunity soldiers.
Yeah, I was, I signed up full knowledge, knowing that I was going to need to continue to come back. I agreed to come back for 15 years to come back and give blood so they can continue to test and make sure that what they put in me is continuing to work and see how well it was working. The first 2 years, I came back every 90 days. I came back every 3 months. And as I would come back, we would do blood work, we would do a PET scan, and then I would meet with the team. And the team would, there'd be 3 or 4 at the time. Dr. Olawale was one that I continue to stay in contact with. And then so after those first 2 years, I would, like I said, every 3 months, it was like clockwork. I'm going down to Vandy, I'm going down to Vandy, I'm going down to Vandy. And then now I'm in a stage where I'm going once a year, and they're monitoring both my blood and they're still doing PET scans. During that time, I had no doubt and that what they did was going to continue to work. I felt good. They told me it's going to take me at least 2 years to kind of get back to where I was. And I said, no, I'm going to do it in 6 months. Well, yeah, it took 2 years. My health, like Dr. Dholaria said, couple things that were continuing lag type things where my immune system was compromised, right? And so I had to do infusions on my own where I would infuse immunoglobulins to help keep my immune system up. I put 3 needles into my belly once every, started off every other week, went to every 3 weeks, eventually once a month. And we weaned myself off of that as my immune system built itself back up. And it's still low today. I can tell you that one of the things that, when someone around me, Patti, gets the flu, guess what? I have to start Tamiflu right away. And matter of fact, several weeks ago, I ended up with the flu bug that put me down and out. So, yeah, it's an ongoing process. I'm happy to have to deal with that compared to the alternative. But I can tell you that everything that's happened was explained as a possibility. It's a shame to me to have to say that I touched every one of those bases along the way. Just I wish I'd pass on some of those, but no, I'm doing everything as they described, as they told me what happened has happened. So no surprises.
It never approached me as a problem for him to go back for the scans because it's especially since we're someone who, after the 8 rounds of chemo, then when you got that scan that it came back, getting to go, that was an honor to get to go back every 3 months and have someone tell you it's still gone. It's still gone. It's still gone. There's, yeah, you're grateful for that. That's not a problem. We'll be there. We'll be there. Please.
Some people call that scanxiety, right? Your scan anxiety. Yeah, you have that a little bit, but I'm very confident in where I'm at today. Played pickleball this morning, 6 games. I won 3, lost 3, but I was out there knocking pickleball around here in Florida. So I'm at a point where I feel like I've got to the recovery and I got past that 2-year mark, which was I think an important key indicator.
So, was there some recommendations or mandatory things to do or not to do? Any specific diet recommendation you were given, or you just followed common sense?
Yeah, I would say one thing. I did have some nutrition folks meet with me, but I think there needs to be a little bit more aggressive approach to what you eat, what vitamins you take, how you eat. Patti and I have done some research and we're doing intermittent fasting, for example. And as a result of eating better and doing the intermittent fasting, and this is unintentional. I've lost 30 pounds. And I didn't do it to necessarily lose the weight. I did it to feel better. And I'm feeling much better today in what I'm eating, how I'm eating it, the exercise that we're doing, especially being down here in Florida where it's nice and warm and we don't, kind of skipped winter, right? So I feel like I'm in a really good spot right now. And, it's the diet piece of it. I wish we'd have had more discussions on. When you're in the hospital, you eat the hospital food, right? And it's not always it's good, but it's not always the best for you. But having a little bit more better understanding of nutrition, I think is another piece of this puzzle that could be put together to make this even more powerful.
I think that's something it's newish as far as research is there, that how much your gut health and the amount of carbs you eat and kind of things. People don't understand how much that can make you feel better if you make just some tiny little tweaks.
Fantastic. So, Baggy, beyond lymphoma, which was the cancer of David, what are today, because we have a broad audience, the current indications? Who are the patients? What type of cancers and maybe non-malignant diseases, as we've seen recently, who are eligible to receive CAR T cells? Without going into the details, just to give some hope, I think, to those watching us and who will view this broadcast on demand.
Yeah, no. So, like you said, after the initial successes in lymphoma, we have tested different types of CAR T in acute leukemia, especially acute lymphoblastic leukemia in children and adults. So now we have that available for after they fail chemotherapy. We also have 2 different types of CAR T cell therapy available for other type of bone marrow cancer called multiple myeloma, which is also an immune system related cancer, affects the bone and the blood and the kidney. And apart from that, there has been ongoing trial going on of using the CAR T cell therapy for several rare type of lymphoma. Also, as you mentioned, because this CAR T cell therapy is quite immunosuppressive, people are trying to figure out if they can be used to turn off patients with autoimmune disease, such as lupus, multiple sclerosis, systemic scleroderma, because in those patients' own immune system is the one causing problem and attacking their body and causing the organ dysfunction. So these CAR Ts is one and done, could be one and done type of treatment where they can switch off this autoreactive immune cell and provide long-term remission. So we have those trials currently enrolling at Vanderbilt, addressing those patients. So I think the future is quite exciting when it comes to cellular therapies. We are now using the donor-derived CAR T, so we don't even have to collect patients' immune cells to make the CAR T as a part of our trial here. And the indications for the CAR Ts are ever increasing in more and more patients, including now we have trial going on with newly diagnosed lymphoma patients who had no chemotherapy and going straight to CAR T, hoping that we can actually give them less chemo and still cure probably more patients.
Fantastic. I think this is an important message of hope. So now we're reaching the end of this webinar. So the closing comments, remarks are for you, David and Patti. What you would like to say to those patients who are candidate to CAR T cell or already received CAR T cells, and maybe not everybody is today doing well and enjoying life like you. I think patients have some different experiences, but I would love to hear your concluding remarks.
Yeah, I think every patient is going to have what they're going to have. It's going to be something different. My outcome. I feel blessed for having the outcome that I had. We also feel blessed because we had the opportunity to be able to go to Santa Monica, California, to the lab that actually re-engineered my cell. That was the only piece of the whole puzzle I hadn't seen, and I was able to go there, meet the people who, in fact, are doing that re-engineering. Patti and I were able to do a video for Tecartus, which is a product that is part of the company Kite. So if you want to see this whole story again, you can go to tecartus.com and look us up. But the fact is that all along we felt confident that what we were going to do was going to happen in the time frame it was going to happen in. I had a tattoo put on my back, and it was just a lymphoma flag, and it's got my rebirth date 9/20/21. And so I can say now that lymphoma is behind me. And I really wanted to put it on my right butt cheek, but Patti told me it wasn't a good idea to be pulling my pants down, showing people my tattoo all the time. So I had to do it on my back, my right shoulder. So
I think also, when you're going through this, there were people in the hospital who told us many times, your attitude is very, very important. It's not easy. It's not easy to stay positive. It's not easy when all these things are coming at you. But you have to find those ways, whether it be from support, whether truly listening to your doctors. If they're not scared, then you should not be scared, because they will tell you. They will tell you if it's a problem, and believe them. And that's hard when you're doing such a hard thing. But I found that very helpful for us. And letting other people know, letting people support us. We had a way to kind of, it was contained, but also that, just letting other people send those good thoughts to us. Some people, when they're diagnosed with this, they kind of want to hide. They don't want to be exposed. If you can, it's helpful, because the other people supporting you, telling you got this, praying for you, whatever it might be, is also very helpful. Yes, it's hard. It's not easy. This is not going to take 2 minutes and then you're better. It's going to be a journey, but there's a lot of hope there. There's a lot of hope. And this is a cancer, these lymphomas, this is a cancer where it's changing almost daily how they're treating it. And so you can't give up, because they got more stuff. They got more stuff. And I think we're hearing that from, what Dr. Dholaria has told us. So I feel like, there's hope.
Fantastic. I think this is a beautiful conclusion, a keyword, hope, and we never give up. You're absolutely right. Thank you, David. Thank you, Patti. Thank you, Dr. Dholaria, for sharing your journey. We feel really blessed and privileged here at the ICH, having you to launch this ICH for Patient initiative. I think you did great, and I really admire your spirit. You're definitely a hero, and you can be proud of this. So thank you all for following the ICH activities. Thank you to everybody who made this happen. And wherever you are, please stay safe and keep well. See you soon.
thank you. God bless.
Thank you.